Thank you all so much for joining us today for part one of this webinar series on cardiac amyloidosis. The topic for today will be, who should I be testing for amyloidosis? And I'm joined by my colleagues, Dr. Ariane Macedo and Dr. Barry Trachtenberg, who will be speaking later in the hour. So we have three main learning objectives for today. Number one, we will discuss the most common types of cardiac amyloidosis. Number two, we will identify patient populations with increased prevalence of cardiac amyloidosis. And number three, we'll discuss the clinical presentation of cardiac amyloidosis, including key red flag findings. So what is amyloidosis? Broadly speaking, this term describes a group of disorders whereby a normal serum protein misfolds for various reasons into a beta-pleated sheet dominant structure. These beta-pleated sheet proteins then aggregate into amyloid fibrils, which then deposit in organ tissue and cause organ dysfunction. Now, in humans, there are over 36 different types of amyloid proteins that have been associated with disease. However, for cardiac amyloidosis, this is caused primarily just by two types of amyloid proteins, and so these will be the focus of our talk today. The first type is immunoglobulin light chains, which causes light chain amyloidosis, abbreviated as AL. And the second is the transthyretin protein, which causes transthyretin amyloidosis, abbreviated as ATTR. So we'll start first discussing a little bit more about light chain amyloidosis, or AL. So AL is really plasma cell neoplasm, meaning it's a disease, a clonal disorder of plasma cells. And these clonal plasma cells then produce excess free light chains, which then misfold and aggregate as amyloid fibrils. It's somewhat related to other plasma cell neoplasms like multiple myeloma or MGUS, although not totally the same, and people with MGUS are at risk for developing AL, and about 10% of patients with multiple myeloma do end up going on to develop AL as well. Now, in general, AL is a rare disease. It's thought to have an incidence of about 40 cases per million, and really has a pretty variable age of onset. Now, transthyretin amyloidosis, however, is quite different. This results from dissociation and misfolding of the transthyretin protein. This protein is made in the liver, and it's a serum transport protein for retinol and thyroxine, hence the name transthyretin. So there's two main types of ATTR. The first type is a hereditary type, whereby there's a mutation in the transthyretin gene, and this predisposes the protein to misfold and aggregate as amyloid. In the United States, the V122I mutation is the most common mutation that causes ATTR, and this mutation is actually present in about 3 to 4% of African Americans, though with variable penetrance. So of course, the actual prevalence of disease is not quite so high. The other main type of ATTR is a wild type form, whereby a genetically normal transthyretin protein still misfolds, really for reasons that are remain somewhat unclear. Wild type ATTR is a disease of the elderly with a median age of 76 at diagnosis, and this typically affects Caucasian men. One thing that we do know about wild type ATTR is that it appears to be significantly underdiagnosed. And over the next few slides, I'll show you some examples of populations in which this appears to be the case. So this first study was looking at patients with heart failure with preserved ejection fraction. They looked at 108 patients who were referred to a HFpEF clinic and underwent cardiac biopsy in the mid-2010s or so. And they found a 14% prevalence of amyloidosis in this population. Now, the majority of patients did have wild type ATTR. However, there was a smattering of hereditary ATTR as well as AL and even AA, which is inflammatory amyloidosis associated with the systemic inflammatory syndrome. They did kind of note some predictors of amyloidosis on the biopsy, and these were somewhat as you would expect: older age, lower blood pressure, lower BMI, and then increased cardiac biomarkers as well as LV mass index. This next study also focused on patients with HFpEF, but looked specifically at inpatients who were admitted with heart failure. So this was done as a single center study in Spain, and investigators screened consecutive patients over the age of 60 who were admitted for HFpEF, and specifically screened them with a bone scintigraphy scan, looking for ATTR cardiac amyloidosis. And again, they found that about 13% of these patients had wild-type TTR cardiac amyloidosis, which is quite a decent number if you think of all the HFpEF emissions that we have. The second population that appears to have a high prevalence of cardiac amyloidosis, wild-type ATTR, is those with patients with severe aortic stenosis. There have been a number of studies looking at this, and I highlighted those in the table in the lower right-hand corner of the slide. However, this main study that's highlighted just came out last year and describes a multi-center British experience where they looked at 200 consecutive patients that were referred for TAVR evaluation. Again, these patients were screened with bone scintigraphy, and they found that 13% of these patients had wild-type TTR cardiac amyloidosis. Again, these investigators looked for predictors that identified patients with AS and amyloid as opposed to AS alone. And somewhat similar findings shook out: older age, increased LV wall thickness and LV mass index, higher cardiac biomarkers, and interestingly, lower pre-TAVR quality of life. Now, the final group of patients I'll talk about this morning is those with carpal tunnel syndrome. So this was a study also that came out last year looking, published by an Italian amyloid center, where they compared the prevalence of carpal tunnel syndrome in their amyloidosis population against the carpal tunnel prevalence in the general Italian population. You can see in the upper right-hand corner, in the dotted line, that shows the kind of the background prevalence of carpal tunnel syndrome in the general population. And then in the bar graph, it shows the prevalence of carpal tunnel syndrome in patients with wild-type ATTR with cardiac involvement. And you can see that it's several times higher at about 26%. Those bottom two figures show that the diagnosis of carpal tunnel syndrome usually predates the diagnosis of amyloidosis by a fair amount. In men, you can see that over 20% of the time carpal tunnel was diagnosed 5 to 9 years before diagnosis of amyloid, and in about 5% of cases it was diagnosed more than a decade prior. So unfortunately, diagnostic delay remains common for patients with cardiac amyloidosis, and that's part of the impetus for doing this webinar series here with Eidos. So this study came out of Hopkins about 3 years ago now, and they looked at 82 patients who had been diagnosed with cardiac amyloidosis by cardiac biopsy at their institution, and they found that the median time from first symptom to onset to biopsy diagnosis was 21 months overall. So that's nearly 2 years. And this delay was even longer for patients with ATTR as compared to patients with AL. So we clearly have a lot of work to do to improve diagnosis for these patients, which in turn will then improve outcomes. This study focused on patients with AL. And it was actually a survey-based study where they asked patients about their experience going through the AL diagnosis process. And kind of in that middle of that table there, they asked patients how many different physicians they visited before establishing the diagnosis of AL. And over 30% of patients reported seeing at least 5 physicians prior to receiving the correct diagnosis. On the right side of the slide, you can see that the first physician visited was a primary care physician in the vast majority of the cases. And so I think in addition to reaching out to cardiologists and oncologists, we have a lot of work to do also with educating our primary care colleagues to help them identify patients who may warrant a targeted referral. And then switching back to the bottom of the table again, if you look at the specialty of the diagnosing physician, a cardiologist was the diagnosing physician only about 19% of the time, even though the heart is one of the most commonly involved organs in AL. So again, just highlighting kind of the work that we still have to do. So with that, I will move along to clinical presentation and hand things over to Dr. Trachtenberg.
Thank you so much, Dr. Zhang, and thank you to Eidos for the invitation to present today. So turning towards the clinical presentation, see if I can move my slides here. Great, okay. So we'll talk a little bit about the presentation of TTR and AL. And so for TTR amyloidosis, whether it's wild type or hereditary, heart failure is a prominent feature, of course, and conduction disease and arrhythmias as well. And for both wild type and hereditary TTR, you can see bilateral carpal tunnel syndrome or unilateral, as well as lumbar spinal stenosis. And as Dr. Zhang mentioned, especially with wild type, the delay between the onset of carpal tunnel and the onset of cardiac symptoms can be quite large in the measured by years. So if you have a patient that has, for example, sometimes our orthopedic surgeons now that are very attuned to amyloidosis will biopsy carpal tunnels in appropriate patients, and we'll see patients that have amyloid, and they have, when we study their heart, they have no cardiac manifestations. But that doesn't mean you send them home and say, you have a clean bill of health. These patients need to be followed for years because they are at risk for developing cardiac manifestations. In addition to these symptoms that you see here on the left, hereditary TTR has a greater burden of neuropathy. So in addition to central motor peripheral neuropathy, autonomic neuropathy is very common. We see a lot of orthostatic hypotension, but not just orthostatic hypotension. We also have patients with a lot of GI autonomic dysfunction that might manifest as early satiety, weight loss, diarrhea, constipation. In addition, some other things that you might see would be disorders in sweating, erectile dysfunction, glaucoma, etc. This is by no means an exhaustive list, but these are some of the more common symptoms you might have. And I think it's important to realize that in the TTR gene, there's over 130 known mutations. All of them that cause the disease have an autosomal dominant transmission. That said, if you are a carrier, as Kathleen mentioned, 3 to 4% of African Americans are carriers with the V122 mutation. You might notice here a little bit different nomenclature. All the V122 is now V142, the T60s, T80. There's 20 base pairs were added a few years ago, so you might see both in the literature if that's confusing, but they're the same mutation, just different nomenclature. But so even if you have that mutation, the penetrance is not complete. It's not exactly known what the penetrance is, but having the mutation doesn't mean necessarily that you will have the disease. There are now 2 companies that are offering free genetic testing, so it has eased the burden on the patient to get genetic testing done. And what this slide is really helpful to know is that no matter what mutation you have, even though you might have that mutation might carry a predilection towards having cardiac features or alternatively neurologic features, no matter what mutation you have, it's possible to have both cardiac and neurological features. So for example, here we see highlighted in the red circle, these are the 2 most common mutations you'll see in the United States. So the V122 or the V142, about 95, and this data is adapted from Martha Grogan's data from Mayo and from the Thales registry data. So about 95% of patients with the V122 mutation will have cardiac manifestations, and approximately half will have some neurological manifestations, especially sensory. A lot of these patients, if you ask them about neurological symptoms, they may not really be attuned to it, or they may deny it. But if you send them to neurologists and undergo formal testing, you'd be surprised at how many that seem to be asymptomatic from a neurological standpoint have significant neurological deficits on nerve conduction studies or EMGs. The second most common mutation in the United States is the T60 or the T80 ALA variant. This comes from an Irish background, so a lot of American Appalachian folks will have this variant. It does have a very prominent cardiac manifestation, as well. And about 2/3 of patients will have neurological manifestations, especially autonomic and autonomic GI symptoms, which are often really not diagnosed correctly for a long time. It's a lot of lack of awareness of that being the cause of their symptoms. The third most common variant in the United States and the most common mutation in Europe, in Japan, is the V30MET or the Val50MET mutation. And there's two, onsets of this. One is the early onset form, which occurs in patients typically in their 30s. And this is the most common cause of familial amyloidosis polyneuropathy with almost ubiquitous neurological manifestations. The early form, slightly less than 1/3 will have cardiac manifestations, but the late onset form, which occurs in middle age, about half of patients will have cardiac manifestations. But regardless of what mutation you have, you can have either cardiac or neurological or both manifestations. So for AL amyloidosis or light chain amyloidosis, heart failure certainly is very common. Atrial arrhythmias and conduction disease. Proteinuria, which can happen in TTR, but much less likely, is very common in AL, and nephrotic syndrome is common. In addition, autonomic dysfunction occurs with light chain amyloidosis, manifesting with the similar symptoms of orthostatic hypotension, GI manifestations. And then I think it's really important to highlight these two that are with the asterisks, the macroglossia and the periorbital purpura. These are specific to light chain. These should not occur in TTR. So these are clinical findings that you might see in exam that should clue you in to a patient having light chain amyloidosis. In terms of the organ burden of disease, for AL, the heart is very commonly involved, upwards of 80% in this review. Kidney over 60% of the time, and you can see other organs involved here as well. In addition, AL can cause cutaneous manifestations that have a preference for skin folds, including the eyelids, the retroauricular area, neck, axilla, umbilical, and anogenital area. And you can see some pictures here of examples of this. So in terms of some imaging or clues that we should pay attention to, one is the EKG, and we often talk about the finding of having a thick heart on an echo or MRI with an EKG that has relatively low voltage that is discordant with what we would see if we had true left ventricular hypertrophy. But instead we have fibril deposition in the heart, causing it to appear to be thicker, but it's actually not hypertrophy in the true sense of muscle hypertrophy. That's why you see that discordance. That said, you don't have to see that on an EKG. And in fact, the most common finding on an EKG is is a pseudo-infarct pattern that you see in V1 to V3 here in this patient. In addition, you might see AV block or other manifestations of conduction disease. And on the echo, you see some characteristic findings here. In panel B, you see the typical biventricular increased wall thickness. You see biatrial enlargement and that quote-unquote restrictive cardiomyopathy. And then in panel C, you see the increased wall thickness as well. You also see, it's very common to see some pericardial effusions and or pleural effusions. Panel D is from a TE showing you a left atrial thrombus, which is very common in patients with amyloidosis, and often they may not respond to anticoagulation. And then in panel E, you see the classic strain pattern of apical sparing. So in the apex, you see the red with the relatively normal or preserved strain pattern, but in the base and the rest of the heart, you see very abnormal strain. And so this is the classic apical sparing pattern, or the target sign, or the cherry on top, however you want to call it, that is something you might see. So these are some of the red flags for cardiac amyloidosis in general. The cardiac red flags, certainly the imaging ones that we discussed. In addition, having heart failure with unexplained LVH without hypertension or aortic stenosis. Patients that are intolerant or maybe worsening despite typical treatment with ACE inhibitors and ARNIs and beta blockers. Patients with low flow, low gradient aortic stenosis. If you have a patient that's an elderly patient that all of a sudden has a new diagnosis of hypertrophic cardiomyopathy, that should be a red flag. The apical sparing sign that we mentioned. Patients with advanced AV block or conduction disease that suggests infiltrative disease. And then certainly a family history of sudden cardiac death in a patient with any of the above. So it's really important that you're taking a family history in your patients, which we should do in all our patients with heart failure. Renal, unexplained proteinuria, orthopedic. I do a very quick orthopedic history on my patients, asking them about carpal tunnel, asking them about lumbar spinal stenosis. Also, the biceps tendon rupture can occur, especially in TTR patients with the Popeye sign. And then patients may have just multiple knee, hip, shoulder replacements, which are more common in amyloid than the general population. In terms of neurological red flags, unexplained peripheral neuropathy, patients that don't have diabetes or have very well-controlled diabetes are often, given, other diagnoses to cause their neuropathy, because people may not be aware of amyloid. They may put them on treatment of CIDP and they're not getting better. That can be a clue that this is not that this may be amyloid. And in terms of how to go about diagnosing someone once you suspect amyloid, so if you have any of these findings that are suggestive of amyloid, then the first step to screen them is and the most important first step is really to rule out a monoclonal protein. So to do that, it's not just a serum kappa lambda free light chain, but that is a very important test, and we'll talk about that. But also looking at your serum and urine immunofixation and electrophoresis are very important. So doing all three of those tests to really have the yield to rule out a monoclonal protein spike is hugely important. If any of those tests are abnormal, then you want to send them to hematology. And if they think it's appropriate, they might order a bone marrow biopsy. Or if not, then a biopsy of any organ involved, or perhaps a fat pad biopsy. If the monoclonal protein workup is completely negative, then you can go to your non-invasive pathway of ordering a nuclear scintigraphy or technetium pyrophosphate scan. And if that's positive with a totally normal monoclonal protein, then that's very sensitive and specific for TTR. And then you can do genetic testing to determine if it's wild type or if it's variant. However, if you don't have bone scintigraphy available, or for any other reason, if there's a potential MGUS that kind of negates the sensitivity and specificity of your technetium pyrophosphate, then you would consider a cardiac biopsy. Or if you don't have scintigraphy available, you would go straight to a cardiac biopsy, and that should give you your data. And that will do genetic testing on the biopsy as well. But if it's negative and if it says wild type, there's still about an 8% chance that it could be missing a variation. So I will still send genetic testing in that instance. And in terms of bone scintigraphy, I think there's a couple important caveats. One, I mentioned it's really important. I'm going to highlight this again. You have to exclude a monoclonal protein workup, a monoclonal protein spike, prior to getting a nuclear scintigraphy. Otherwise, all the studies that showed how sensitive and specific this test was ensured that you had a negative monoclonal protein workup. And on top of it, you don't want to miss light chain amyloidosis or delay the diagnosis of light chain, which is really more of a medical emergency. It's recommended to use SPECT imaging when you do your nuclear scintigraphy. That way you can exclude a blood pooling. And this is just an example. You see uptake there in the heart, much higher than you would in the bones. And then one, really kind of important caveat. This paper came out recently, just an opinion paper, but I think it's really important to highlight. This is a very common question that comes up from referring physicians. Is the free light chain ratio that we all use and that our lab uses really assumes a normal GFR. So, and the light chains are cleared two ways: one by the kidney, one by the reticuloendothelial system. And the normal bone marrow produces more kappa than lambda. But when you have a normal kidney, it's able to clear kappa more efficiently than the lambda. So that's why your ratio in a normal scenario with the normal kidneys typically is often less than 1 or around 1. As your GFR starts to drop, your renal clearance contributes a little bit less, and the serum concentration of both the kappa and lambda will rise. Thus, you have a kappa and lambda ratio that's increasingly from a normal kappa production by the bone marrow. So, for example, if your GFR starts to drop in that 40 to 60 range, you can see what a normal ratio might be 0.5 to 2. So if you have a lambda variant, you might have a 0.26 to 0.5 in that ratio that is really going to be abnormal, but your lab might call that normal. In addition, as your GFR really starts to decline, then you're not able to clear the kappa even less efficiently. And then your kappa to lambda ratio reflects higher kappa. And in this example, it shows here that the quote normal ratio might be as high as 2.25. I think certainly that's a conservative cutoff. We often see up to 3 or even sometimes higher. So that you may want to consider biopsies in this situation or talk to your hematologist depending on the clinical scenario. So the first presentation is 87-year-old white male who presents to the TAVR clinic. Sorry, there's a slight delay on the clicker. So the patient comes in with 2 months of dyspnea on exertion, recently admitted for volume overload. His echo shows a preserved EF with mild concentric LVH. And moderate aortic stenosis with a mean gradient of 24 millimeters of mercury, aortic valve area 1.3 centimeters squared. Recently underwent a PCI of an RCA lesion, and then was referred to the valve clinic for evaluation of his aortic stenosis. You can see past medical history here, including persistent atrial fibrillation, CKD, and some COPD, and you can see his medications. On the EKG, you can see we talked about this patient has the classic pseudo-infarct pattern and appears to be in atrial fibrillation. The limb voltage is a little bit low as well. On his echo, and sorry, we don't have moving pictures, but on the still pictures, you can appreciate the concentric LVH as well as RVH in this patient. And you can see on the right-hand panel, the patient with a heavily calcified aortic valve with restricted motion. Here you can see the gradient, and the aortic valve area is 0.9 centimeters, and the gradient is mean of 15 with max gradient of 29. And the patient on a strain, you can see, has the classic apical sparing pattern. The patient underwent NT-BNP and troponin, helping to stage the amyloid that was later discovered. He underwent, so the patient, he had a simultaneous monoclonal protein workup. And then I think what happened with this patient is he got a technecian PYP before we got the monoclonal protein workup back. We should not have done that, but that's a good example of why we should take the appropriate steps. So he actually had a positive monoclonal protein on it, S-pi, and he also had a positive technetium pyrophosphate. But again, just using this example to show that the technetium pyrophosphate was really only validated if you had a completely negative monoclonal protein workup. So this patient ended up being seen by hematology, and he had, we ended up doing a biopsy of his heart so we can be definitive about his diagnosis. And he ended up having transthyretin by mass spec, and his genetic testing, both on the cardiac biopsy sample and subsequently on the blood sample, were negative for any mutations. This patient was diagnosed with wild type, so this is a patient that was suspected to have, that did have low flow, low gradient AS, but also was found to have a wild type TTR. So that's just one example of many ways that we end up coming in a roundabout way towards the diagnosis of TTR amyloid. And Dr. Zhang now will be presenting some other cases.
Thank you. And just to kind of briefly comment on the previous case, the initial amyloid evaluation in that case had been started by physicians in the TAVR clinic who really were not as familiar with the appropriate protocol of, the order of how to test for various aspects of amyloidosis. So, just goes to show how you need to be somewhat nimble in interpreting those test results and ordering additional tests like a cardiac biopsy as appropriate. Okay, so our next case similarly showed somewhat of a roundabout method of getting to the diagnosis of amyloidosis. So this was a 67-year-old Black male who presented to the hospital initially with weakness. He reported a long history of bilateral leg weakness and eventually had a fall due to his legs giving out, which prompted the kind of the sentinel ER presentation. In the ER, because of the fall, he did undergo a spine MRI, and this showed severe cervical and lumbar spinal stenosis. Because of this, he was admitted to the neurosurgical service and underwent a cervical discectomy as well as foraminotomy. Postoperatively, he was noted on telemetry to have non-sustained VT, and so an echocardiogram was ordered to investigate this NSVT. Looking back quickly at his history, he did have a history of heart failure with preserved ejection fraction, hypertension, hyperlipidemia. He also had bilateral carpal tunnel syndrome, status post-release, as well as a history of sciatica. Also had been previously found to have non-obstructive CAD by a left heart cath. He was on no medications and was currently smoking, and a history of cocaine use. So when he went for this kind of post-op echo, the actual echo itself looked quite unremarkable. There was kind of normal LV wall thickness for the most part, kind of global hypokinesis, and the only thing that was maybe mildly suspicious for amyloidosis was the strain analysis, which showed a markedly reduced global longitudinal strain at -9%. And also an apical sparing pattern of strain, which, as Dr. Trachtenberg mentioned, can be highly suggestive of cardiac amyloidosis. And so because of this echocardiographic finding, a further evaluation for amyloidosis was performed. This was the patient's EKG, and really it was not particularly suggestive of amyloidosis. The patient was in sinus rhythm. There was no obvious heart block. There was a Q wave in V1 with that recent left heart cath that was normal, so potentially consistent with pseudoinfarct. So the patient did end up undergoing the monoclonal protein evaluation, which was negative. And so he did proceed to a technetium pyrophosphate scan. Now, you can see there on the planar imaging that the planar imaging was positive with grade 2 cardiac uptake. However, when SPECT imaging was performed, it was found that that uptake was due to blood pooling and of tracer within the LV cavity and not actually intramyocardial tracer uptake. And so the study was interpreted as being negative for ATTR. Now, because there remained very high clinical suspicion for cardiac amyloidosis, the patient did go on to a cardiac biopsy. And this did come back positive for cardiac amyloidosis by Congo red stain. When the sample was sent for mass spectrometry, it was confirmed to pre-transthyretin mutant type, And then the genetic testing did confirm that this was V122I mutation. I'll also point out that this patient's cardiac biomarkers were quite abnormal, and that we can also see that, actually we see that, pretty much all the time in patients with cardiac amyloidosis. So this patient had hereditary transthyretin cardiac amyloidosis, specifically with a V122I mutation, with the heart failure, lumbar stenosis, and bilateral carpal tunnel syndrome in an African American patient. And then with that, I'll turn it over to Dr. Macedo.
So it's a 41-year-old female that presented with dyspnea. She had a previous, she was previously healthy with regular exercise, no medication, no previous cardiovascular disease. So she presented with 3 weeks of dyspnea on a section, and also lower extremity edema, orthopnea, and it was performed a CAT. And her left heart characterization, there's no obstructive coronary artery disease, but on the right chambers, we can see over pressure, increase in the pressure load with 15 millimeters of mercury, and also elevation on the left chamber pressure. All the review of the system was not important, but only abdominal pain. So the workup diagnosis, we performed echo, and the echo has shown the hypertrophy with moderate concentric left ventricular hypertrophy with a normal ejection fraction, left ventricular ejection fraction. It's important to say that we can see in the septum a more sparkling sign in the septum that maybe could be a clue to find the infiltration in this case. But the strain, we can see a very specific point of the apice where the motility is preserved. So maybe a clue also for the diagnosis. And the ECG, we can see, the ECG, we can see a low voltage in the limbs, and we cannot see that specific inferior infarction pattern that we have seen before. So for the diagnosis, this lady was, we had the biochemical samples, and then we can see elevation on ENT, proBNP, and also troponin. And Kate has already said it's so frequent that we have this chronically elevated in this patient. So we know that it is a marker for prognosis as well. But also it's important to know that because usually these patients go to the ER, and usually they have more than one cardiac characterization because of this chronically elevation troponin level. So sometimes it's important to say to the patient that he has or she has chronic elevation of troponin. But more importantly, it was performed the electrophoresis of the protein, and here we can see elevation, the Kaplan-Meier ratio of in a very high level. It's very different from the previous case when we have a slightly elevation of this ratio. In this case, it's she was indicated hematologic evaluation, and we have here a bone marrow biopsy with 3% of clonal plasma cell population and positive for amyloid deposition by the Congo red, as we can see here in this figure. And also it was performed a biopsy of the gastric and the small bowel biopsies that we can see the positive Congo red presentation. That's positive for amyloid. As it was already said, it's important to have the specificity of this amyloid. We can see the amorphous material here, but we need to know what type is. So it was performed a spectrometry, and it was a AL kappa amyloid. And this lady needs to be treated urgently because this is a medical emergency to be treated soon, since she has a cardiac involvement. And to finalize it, she was performed with a cardiac MRI, and we can see the diffuse gadolinium-latent enhancement in the left ventricle and right ventricle, that it was very consistent with cardiac amyloidosis. So the final diagnosis, we have the image, we have the symptoms, and we have the biopsy showing the AL kappa amyloidosis. So the final diagnosis is AL cardiac amyloidosis. Thank you, Kate. I'm back to you.
Thank you all so much. This is Dan Linehan. I have the great pleasure of working with Dr. Zhang directly, and then, of course, our other faculty by extension as often as possible. So I appreciate all of the great presentations. There are several questions in the chat box. I don't know if you can see them. If you can't see them, I can read them. And then, I'm sorry. Okay. So the first question for Dr. Zhang: what key features on standard imaging or testing would make you suspicious to pursue amyloidosis?
Yeah, that's a really, that's a kind of a loaded question. I mean, I think the textbook answer is, markedly increased LV wall thickness, low voltage on EKG, apical sparing pattern of strain. Those things would definitely scream cardiac amyloidosis. I think the issue is that, obviously there are a lot of things that can cause increased LV wall thickness in our patients. And then actually we did a recent study just at our WashU patient population and looked at the kind of the prevalence of low voltage in patients with cardiac biopsy proven cardiac amyloidosis, and it was not a very sensitive finding, really. So, I think that part of the takeaway from this presentation is that the diagnosis is really difficult to make, and so you need to be kind of take information from all different parts of the examination. So, look at the cardiac imaging, but also, look for red flag findings in the medical history or on physical exam, or look for that chronically elevated troponin, like Dr. Macedo was saying. So yeah, I think that it's important to be aware of these kind of red flag imaging findings. But obviously those things, some of those things are common in the population, and then maybe they don't have quite the sensitivity or specificity that we would want them to have. And so, keeping a broad eye on the whole clinical presentation is important.
Yeah, if I can just echo what Dr. Zhang said, I mean, I think that's so important what she said. And I think the question we have to move away from the thinking of, these, giant red flags that have to jump out at us towards us being more proactive to look for amyloid. I mean, if you looked at what Dr. Zhang presented earlier, about 13 to 15% of HFpEF is amyloid. So we're missing it all the time. And so I think three things, really need to be a part of your H&P. And when you see patients in clinic or the hospital, you need to do a family history. You need to do a very brief, it takes 10 seconds, orthopedic history, a neurologic history, just ask 1 to 2 questions about neurologic manifestations. And then also, when you get patients that are coming in with HFpEF, oftentimes they have an echo done somewhere else. It's really incumbent upon you to get those images if you can, so you can see yourself, because there's a pattern there on the echo that you might recognize immediately if you've seen amyloid that you won't glean from the echo report, and the other cardiologists may not have picked up on it. So I think you just have to be more aware that you're missing it often, and we have to, as a community, do a better job of looking for it.
Yeah, I think that, one thing that both Dr. Zhang and Trachtenberg said, but also has been said many times, whenever you present about amyloidosis, is you have to be suspicious of it. If you're not suspicious of it, if you never put it on your list of things, then you'll never find it. And then many of the slides that were shown earlier, that it sort of hides in plain sight in many cases. So, in patients that are getting bilateral carpal tunnel surgery, If you aren't suspicious of it in advance, then you won't do a biopsy. They'll just have their bilateral carpal tunnel surgery. Or if you have somebody who has aortic stenosis and they go through the usual TAVR evaluation and everything confirms amyloidosis, everything confirms aortic stenosis that requires treatment, nobody's going to be suspicious at all. They're just going to proceed with the TAVR. So I think that it does require a higher level of interest in order to find it. That would be my general opinion. I don't know what you guys think about that. And then Dr. Maceda, there's a question in there, what presentation or what things make you order an SPEP if you're somehow becoming suspicious of AL? What is it that tips you off that that's a test that you should order?
Yes, I feel then that AL amyloidosis it's a more systemic disease. So I feel that the cutaneous manifestation, the renal manifestation, the cardiac manifestation, they are very important, but the whole scenario of the patient, they are more, and I feel that they are sicker. They present to us with a more symptomatic disease. Of course, it's not a rule, but in general, when we see a very sick patient and we suspect and we are suspecting of amyloidosis, and we have cutaneous manifestation, a loss of the renal function, and mainly proteinuria, I feel that we need to start ordering the serial protein immunophenotypy and all the free light workout. So I feel that that's the more important clue for AL. They are sicker, and we have a more broad presentation of the clinical signs. I don't know if Barry and Kate would like to add for my comments.
Yeah, I think I would like to hear what they have to say about that. But the other part that I don't know, and Katie and I both have taken care of these patients directly together. And, I think of if there is a serious consideration for AL amyloidosis, I consider that an emergency.
Yes.
I do not want to sit on that. Do not think that evaluating it over the next 3 or 4 months is acceptable. Because once the patient gets really in bad shape, you can't pull them out, or at least it's difficult.
Yes. I feel that this patient need to be hospitalized and have it all work out inside the hospital because maybe it's faster. And I have 2 or 3 times that we lost the patient for sudden death. They were waiting in the hospital, and suddenly we found them dead. So I feel that the feeling that we need to have that really is emergency, that we need to do everything that we want to have the amyloid done, the name of the amyloid, and to start treating. I completely agree with you then.
Barry, what would you say about all that?
Yeah, no, I mean, I agree 100%. I think we've all lost AL patients and been frustrated that we, the timing of their diagnosis or their treatment could have been a little bit earlier. So just to add to that, I think, ordering the free light chain and the SPI and the UPI are incredibly important. If those are positive, yeah, you should get a bone marrow biopsy, but I think it's important that people know that a bone marrow biopsy is not highly sensitive for amyloid. It's actually less than 50% sensitive for amyloid. So a cardiac biopsy is almost 100% sensitive and specific. Fat pad biopsy in between those two. So really, I don't waste a lot of time trying personally. This is my personal bias, doing fat pad biopsies or trying. I'll go straight to a cardiac biopsy if we need the diagnosis quickly, and so we can get patients on treatment as soon as possible.
I think that's such an important point that Barry just mentioned. So, obviously the reason to do the bone marrow biopsy with the abnormal monoclonal protein testing is to look for what kind of monoclonal population is creating that protein. But, all you really get for the most part is just a percentage of how many plasma cells are in the bone marrow. The likelihood that you're going to get amyloid deposition in the bone marrow is really quite low. And so frequently you're still kind of stuck at that point. So, I think for patients with suspected AL, a lot of us will maybe go towards a cardiac MRI if everything else is really, really very consistent with AL. But frequently it's still very confusing. And so, I think for centers that have the luxury of having reliable cardiac biopsy operators, that's definitely the preferred route to go for those patients. And I do think it gets tricky for centers without experienced cardiac biopsy operators in terms of how to go from there. I think for those centers, I would, suggest a cardiac MRI. I don't know what Ariane and Barry think about that.
Yeah, I mean, I think the MRI is a great tool if you have the diagnosis of amyloid elsewhere and just need to confirm that it's in the heart. But ultimately, you're going to have to get tissue from somewhere. So if their bone marrow biopsy is negative for amyloid, then if you don't have a cardiac biopsy available, I would recommend referring someplace where they can do cardiac biopsy, and/or if it's quicker, to at least get a fat pad biopsy. But even a fat pad biopsy sensitivity for AL, depending on which series you read, maybe 70, 80%. So there's still a decent chance of a false negative.
Yeah, so those are all really good points. And this is a somewhat related question from Dr. Valabanani in Southwestern. She asked, if PYP scan is negative, reported blood pooling, such as the patient that was presented, and there's a high suspicion for TTR, would you then use CMR or go directly to an endomyocardial biopsy?
So I'll give you my opinion. I think you guys have seen I'm very pro biopsy. I think if there's
let me just say, Barry, that you're speaking to the choir. We sing that song every day.
Yeah. So yeah,
Katie may not agree with me, but at least in our location, this is discussed, and as a matter of fact, happened yesterday for the exact reason that we're talking about.
Yeah, I mean, a CMR is a great tool, but one, there's a false negativity possibility that's real. Two, even if it's highly likely that it's amyloid, it's not a tissue diagnosis, so you don't know if MRI will not distinguish between TTR and light chain amyloidosis. I don't know if you'll find a hematologist in the world that will treat AL with chemotherapy based on an MRI. So I think in that situation, a biopsy is essential. Nor do I want to treat the patient with expensive drugs for TTR if I don't have a confirmed diagnosis, either with tissue or with a very clear technetium pyrophosphate negative monoclonal protein workup.
For that patient that was presented, I think in that specific situation, a good alternative may have been to obtain the surgical specimens that were removed at the time of spinal surgery and to stain those for Congo red. Unfortunately, I don't think that the surgeons are really in the habit of saving those specimens, and so frequently that needs to be planned ahead of time. But that may have been a possible workaround for that patient.
There are some other questions out there. Let's see if we can get to them. One was from Josh Mitchell, who also is one of our partners here at WashU. And I'm not sure exactly who this might be directed to, so I may toss it out to Barry. But can you comment on the issues that might arise with unexplained LVH? We certainly have seen people that have not been evaluated initially for amyloid due to other comorbidities such as hypertension. And these patients certainly may have amyloid, and it may be important to consider, but it's not pursued. For example, in somebody who has a long history of hypertension, they may just attribute the LVH to the longstanding hypertension. So what is your feeling about those things?
Yeah, I mean, I think the devil's in the details. I think it's, just like the patients with diabetes that have had a hemoglobin A1C that's 6 for 5-10 years, and they have this terrible neuropathy, and their doctor says, oh, it must be the diabetes because you have diabetes. If you have high blood pressure that's controlled, so it's asking the patient how long they've had it, how controlled it is, if it's a reliable patient, looking at their absence or presence of aortic stenosis. I think those details are important. But I think if there's any doubt, it's very easy to do a non-invasive testing on these patients. It's blood, urine, and a nuclear scan without a stress agent. So I think it's asking the family history, seeing if there's any other of these red flags that we've spoken about.
Great. And then Dr. Avi Guha in Ohio was asked, how can we get people to the diagnosis faster than seeing one of the experts or whatever on this call? How do we get to the diagnosis earlier in a broader population, I guess, is the basic question. Ariana, what do you think?
Yeah, I feel that activities like we are doing here, it's just to people start thinking about. I feel that that's the main point when we are teaching our fellows, our medical students. I feel that we need to insert this in their medical skills, like we insert about other diseases that are always surrounding us, like lupus or other disease, tricky disease. I feel that we need to think about, but to go faster in the diagnose, I feel that we need to ask our echo colleagues when they are seeing something that is suspected. I feel that they need to write that this can be amyloidosis, or please exclude the amyloidosis, because I feel that sometimes when we receive the echo with ventricular hypertrophy, even if it's more than 15 millimeters, that we know that it's a very important point of to suspect. But when the doctors see writing that can be amyloidosis, please exclude amyloidosis, I feel that is something that made you make action. So I feel that we need to work together with our echo colleagues to be more in face, to be more clear about the possibility of this diagnosis. I feel that education and work as a team to find the diagnosis. This could be my clue.
So I'll toss this out to whoever wants to take it. What's an alternative to mass spec? What would you consider? Would you consider biopsy in all suspected cases?
So yeah, I mean, mass spec is really the gold standard. I mean, you can also do a biopsy with immunohistochemistry as well, but certainly not everyone needs a biopsy. That's the beauty of the technetium pyrophosphate scan, that in patients with a normal monoclonal protein workup, that you can do a technetium pyrophosphate coupled with genetic testing, and those patients don't need a biopsy, and I think we've proven that. Some patients do need a biopsy if there's any abnormality in the monoclonal protein workup and bone marrow doesn't show amyloid, if there's MGUS or on your monoclonal protein workup, or if there's any indeterminate findings on any of these tests, and you still have a suspicion. But certainly not everyone needs a biopsy.
Great. So Katie, I know we've had a few cases in common where we were surprised. So I don't know if you have any further thoughts on the biopsy and mass spec.
Yeah, I mean, I think it's so critical to do mass spec, and like Barry said, that is the gold standard. We've had several cases where, the patient went for cardiac biopsy, the immunohistochemistry was positive, and patients were getting teed up for chemo, and then, 2 weeks later, the mass spec comes back with transthyretin and not with AL. And I think the issue might be that, patients with renal disease or, other processes may just have, lots of light chains circulating, and those maybe just get stuck to the tissue in some way. And that's what's showing up on the immunohistochemistry. So, I definitely would not rely solely on that. We send out all our specimens to the Mayo Clinic to do mass spec, and I think it's okay to, send your specimens out. We don't expect everyone to do mass spec in-house, but I would say that it's really critical, and there have been several patients who it's significantly changed the course of their treatment, just with the mass spec result.
Great. And then Ariane, what is your experience on mass spec?
Yes, for me, it was a game changer in the amyloidosis area because, for example, here in Brazil, we have a very limited access to cardiac biopsy. So we have, but it's not very in all centers. So having the mass spec now, I feel that we are more, we have access to the diagnosis because usually we stop it on the cardiac biopsy. I can't do it. So because we don't have access, we don't have the lab that can do and can interpret and the mass spectrum. So I feel that for us here, and I feel that for many places in the world, now it's the way that we have to diagnose the majority of the patients. Of course, sometimes we need to refer to a specific center to perform the cardiac biopsy. But for me, I feel that was one of the most important tools that we have now to treat our patients.
Fantastic. Wow, you guys really hit it out of the park, as they say, on this, our first in a series of 4 lectures on amyloidosis. I want to thank you all for a really unbelievable presentation. And of course, I'm going to ask you all for your slides so that I can use them in the future. The other issue is that our next webinar on cardiac amyloidosis, cardiac imaging pearls, will be on September 16th.